Good evening and welcome and hello to everybody to another session of our weekly webinars, Young India Intensives. Today's topic is graphics, a very important topic both for our performance and our work as well as for those of you who are going to be taking exams. Ventilator graphics are an integral part of exams. So it's in two parts. The main focus is on asynchrony to be delivered by Dr. Srikanth Srinivasan sir. All of you are aware of him. He is head of critical care department at Manipal Hospitals, Delhi, and also co-authored a book on ultrasonography in the ICU. The second part, which is much shorter, just run through some abnormal waveforms for you. They are not classically called asynchrony, but they are abnormal waveforms and can be taken up with asynchrony in a loose sort of a way. And to moderate the session, we'll have Dr. Ranjit Chatterjee sir. Sir is Chief and Head of Critical Care at Swami Dayanand Hospital, Delhi. So if you have any questions for the first part by Dr. Srikanth sir, we'll take a break there, and if any questions, any comments from Dr. Ranjit sir, and then we'll have the second part, which is a very short part actually. There are too many slides. So over to you, Dr. Srikanth sir.
Thank you, Dr. Tapesh. So let me just start. You can all see my slides, right?
Yes, the slide of it.
So I will be focusing only on ventilator asynchrony. So I believe that a basic background of waveform analysis, how the waves, the scalars, and the loops look like, people who are listening to this already have a background idea of the same. I'll be focusing upon the more practical aspect of how to identify asynchrony on the bedside. So it's in a sense a more advanced version of how to interpret your loops and scalars. So starting with the basic question, what is asynchrony? Asynchrony is a mismatch between inspiratory effort and the ventilatory support delivered by the ventilator during assisted ventilation. So ventilator is a machine. Obviously, whenever the patient triggers it, it will deliver the breath. If there is any kind of inappropriate settings which is not adequate for the patient, or the patient's requirement is much more than what the ventilators is required give delivery, then there will be some form of asynchrony. The presentation on the bedside can be very subtle, that you can only see it on the waveforms, or they could be overtly, the patient is grossly fighting the ventilator, patient is getting breath, absolutely tachycardic, sweating, red-faced, thrashing around, and you can see that the entire alarms are ringing all over the place. So this could be the entire spectrum of presentation. Even subtle presentations can be very, very deleterious to the patient in the long run, because certain asynchronies will lead to breath stacking, excessively large volumes. And in this current day and age of lung protective ventilation, excessively large volumes can be very, very deleterious, can lead to volume trauma, can lead to further damage. Patients with obstructive airway COPD exacerbations, excessive volumes, excessive breath stacking can lead to autopy, can lead to further hemodynamic deteriorations. So a very close watch for what these asynchronies are and whether they are there or not should always be a part and parcel of your learning of ventilator waveforms. So there are two aspects of ventilation. One is the ventilator aspect, where you can have the asynchrony regarding the four basic tenets of ventilation: trigger, the pressure delivered, the flow, and the cycling. So these are the four basic tenets of ventilation, and you can have asynchrony regarding to all the four. Or you can have asynchrony regarding to the patient conditions. This will include the strength of respiratory muscles, the neural trigger, which may be different from what the ventilatory trigger is, and that will lead to asynchrony. And obviously, inherent mechanics within the patient, that is the resistance in the airways, the compliance of your lungs, and so on. Effectively, asynchronies are observed to some extent in all intubated patients, irrespective of whatever the ventilatory mode may be there. Volume assist control, pressure assist control, or pressure support. This is as per a study in 2015. So there will be some amount of it. However, if the number of asynchronies is more than 10% of the respiratory cycle, then it's considered to be severe. This severe asynchrony occurs in around 12 to 25% of the intubated patients, and those on non-invasive ventilation is almost as high as 43%. So a good amount of asynchrony would exist in our day-to-day practice. We just need to be alert and aware of how to detect them and what to do to avoid it or to reduce the impact of asynchronies. Why do we need to be so concerned? Is because it has poor outcome. Severe asynchronies, when I said more than 10% of the respiratory cycles, leads to prolonged duration of mechanical ventilation. The number of ventilated days increases. For example, if the asynchrony index was less than 10%, the duration of ventilation was around 7 days, between 3 to 20. If more than equal to 10%, it becomes 25 days. So you can very well see how much the length of mechanical ventilation becomes prolonged. And we know that with the increasing length of mechanical ventilation by itself is associated with increasing morbidity and to some extent increasing mortality. And truly, it also increases mortality. With asynchrony index less than 10%, the mortality is lower as compared to that more than 10%. And this is also statistically significant. Coming to what is the ability of our healthcare professionals to identify patient ventilatory asynchrony using waveform analysis. So obviously, educated mind is the one which actually looks for it. If you are trained, which is the white bar, there's those who are non-trained, who are not aware of how to look for it. The number of correctly detected asynchronies will obviously vary. So the eye will only see what the mind already knows, right? So you need to know exactly what these asynchronous look like so that you can detect it accurately. So training obviously improves identification. How do we quantify these asynchronies? The quantification is based on a score called the asynchrony index. It's a ratio expressed in percentage. It's a number of asynchrony events divided by a number of normal breaths plus a number of asynchronous breaths as a denominator, and this is multiplied by 100. Is there a specific cutoff for asynchrony index? We say more than 10%, less than 10%, yes. But as the number of asynchrony index increases, score-wise, if the percentage increases, obviously, the sensitivity and specificity with regards to prolonged mechanical ventilation or poor outcomes in the long run increases. Now, coming from the ventilatory perspective, the asynchrony is broadly divided into the three basic tenets: triggering, cycling, and flow. So you can have asynchronies regards to all these three. And we'll talk about each one of them one at a time. So let's talk about the types of asynchrony with regards to ventilation. We'll be covering the ventilatory aspect, not the patient aspect. The patient aspect will be covered a bit by Dr. Tapesh after this, but we'll talk about the ventilatory aspect. First thing which comes into ventilation is what triggers or what starts the ventilatory cycle. So you can have trigger asynchrony. Trigger asynchrony occurs when the patient's trigger is not set accurately and does not coincide with the neural trigger or what is there in the patient. So the ventilation trigger is not coinciding with the neural trigger. So there's a poor coordination of patients with regards to initiation of inspiration and the ventilator's response to this initiation trigger. So this could be manifesting in the form of delayed triggering. That means the patient's requirement was a few milliseconds before the actual breath started, as triggered by the ventilation. It could be what's called double triggering, where two breaths are being given in one go, or reverse triggering. And this is a rather a newer kind of triggering asynchrony. We'll talk a bit about this. I'll show it exactly what it is. Could be mistriggering, that the patient is trying to take a breath, but no breath is being delivered. Could be auto-triggering, where the patient hasn't triggered any breath by himself, but the ventilators continue to constantly give breaths. So these are the different types of trigger asynchrony which we may have. Second, once the it starts to trigger, then there's a flow. There's a flow of gas. Now, there could be asynchronous with regard to flow also. This manifests in the form of inadequate flow at the onset of inspiration to meet the patient's demand. The flow may be much lesser than what the patient requires. And this is specifically so when the patients are having air hunger. So this manifests very classically in the patients who are having acute lung injury of some form, inflamed lungs, especially during initiation of ventilation or during weaning from ventilation. So they may have flow asynchronies. Then we come to cycling. The cycling means transition from inspiratory phase to an expiratory phase. So when there's a poor coordination of patients' desire to exhale and the ventilator's response in the form of opening of the exhalation valve, then there can be cycling asynchrony. Effectively, it goes to say that the patient wants to exhale, but the ventilation is still continuing in the inspiratory phase, or the exhalation may be premature. So both these things can lead to what's called cycling asynchrony. It could be because of an inappropriately short inspiratory time. The patient required much more longer time before exhalation should start, but the time was very short. Or inappropriately long inspiratory time where the patient wishes to exhale, but the ventilator considers giving the flow for a longer period of time than what is required. And finally, we can come to mode asynchrony, which corresponds to inappropriate mode, which is not ideal for the patient at that given time. So we'll talk about all these types of asynchrony, how they appear, how the waveforms appear, and we'll take them one at a time. So let's start with the first one, which is ineffective or wasted efforts. You can see here in this graphs, this is a volume control mode. Why we say that is that the pressure waveform is fixed, right? It's a pressure control mode where you can see the pressure waveform is fixed and the flow is a decelerating waveform. And the third waveform is the esophageal pressure waveform. Whenever the patient takes a breath, it manifests in the form of a negative deflection in the esophageal pressure waveform. This, if you have an esophageal manometer in place, will tell you that the diaphragm has shown some kind of a contraction and the patient desires a breath to be delivered. But if you see these two waveforms, whether it is actually being translated onto a breath being delivered by the ventilator or not, you can make out by the flow time and the pressure time waveform. The flow time waveform just shows a small spike and there is no corresponding flow after this spike. This flow did not reflect onto a proper flow waveform, as we can see here. Similarly, there's a negative deflection because the patient has taken a negative inspiratory effort and there's a negative deflection, but this negative deflection is not associated with a breath being delivered. You can see negative deflection prior to each of these breaths, and you can see a negative deflection here, which is not followed by a breath. This deflection is followed by a breath. This is not being followed. So when you see this kind of a waveform, normally we only have the flow time and the pressure time scalars. We don't have the esophageal manometer. The esophageal probe here, waveform is just being shown to correlate how it looks like. On the bedside, we'll probably see these two scalars, the flow time scalar and the pressure time scalar. And if we see a negative deflection on the pressure time scalar, which is not followed by a breath, or a positive deflection on a flow time scalar, which is not followed by a breath, then this is what is called ineffective or wasted efforts. So what is happening because of these wasted efforts? The patient is trying to make efforts, the diaphragm is contracting, right? But the breath is not being given. So there is discrepancy between what the patient wants, what the patient's body requires, and what the ventilator is delivering. And this can occur because the trigger threshold, which is being set, the flow trigger or the pressure trigger, whichever is being set, is probably too inappropriate or too high that the ventilator does not recognize the patient's efforts. So how do we correct this? We obviously correct this by adjusting the trigger to a lower setting. If it persists, that the patient continues to have this triggering efforts, but if they are too weak, probably the requirement or the drive of the patient is too high. And based on the circumstances and the condition of the patient, if your ventilatory settings are appropriate, that the minute ventilation is matched, and still the patient continues to have these kind of triggers, then probably the drive is too high. We can just simply sedate the patient and move on to a mandatory mode rather than an assist control kind of a mode. Sedate and paralyze effectively. Or if you feel that the patient is in a weaning stage and there are lots of a lot of ineffective breaths, then obviously we have to adjust the trigger to a lower setting. A decently lower setting would be a flow trigger of around 0.8 liter per minute. Normally we set it around 1 to 2. We can go down to 0.8 as well. So we should be wary of this kind of ineffective efforts, and at what stage the patient condition does this arise. If this arises just after initiation of ventilation during the maintenance phase where we are not planning on weaning, then obviously the drive is too much, and in case your adequate ventilation is being achieved by your whatever settings you have done, then you can obviously sedate the patient a bit more. In case it's coming during the weaning phase where you actually want that each of these breaths should be actually triggered by a breath. Each of these efforts should be surrounded by a triggered breath. And then in case you can actually reduce your trigger sensitivity to a lower settings, which will allow the patient to get a breath with each trigger. So the first answer should not be sedate. Sedation would only occur depending on at what phase of the disease the patient is in, whether he is in the maintenance phase or in the weaning phase. So sedation will always be a step. It's always an answer for most of these asynchronies. But the decision of sedation should be taken by the clinician based on what exactly are they targeting. Are they targeting the patient to take more breaths, encouraging the patient to take more breaths, or are they encouraging that the patient should breathe in a specific way, which the clinician wants, a more lung protective way for that matter, right? So it is based on that. Now, a specific type of wasted effort is when there is a lot of autopy. This especially occurs in patients with acute exacerbation of COPD, and especially in the weaning phase. Now we are coming to the point where we were discussing previously, in the weaning phase, when the patient has too much autopy and there is difficulty for him or her to trigger a breath. And this is very well seen here. If you see the pressure time scaler here, if you see the pressure time scaler, you can see this is the set peep, this is the auto peep, and there's a huge gap between the auto peep and the delivered peep. And this patient must generate a massively negative pressure to overcome auto peep. This amount of negative pressure which the patient has to set before any kind of flow is generated. How do we handle this? First of all, we do an expiratory hold to see an auto peep, right? An expiratory hold maneuver will give you an average of the auto peep within the respiratory system. Mind you, it's a very non-homogeneous system in COPD or even in severe asthma for that matter. So it's the expiratory hold gives you an average of the auto peep. So that tells you that this would be the basic amount of auto peep which is there. It could be higher, it could be lower in certain ventilatory and respiratory units. It's totally possible. But given the average, we try to keep the peep, set peep, as around 80 to 90% of the auto peep. When we do that, we are actually reducing this amount of negative effort which the patient has to take before any kind of flow is generated. So effectively, this behaves like what's called a Starling resistor. Starling resistor is a rigid tube above, a relatively rigid tube below, and a collapsible segment in the middle. So if just because of loss of traction, there is auto compression of these collapsible airways, especially in COPD, which leads to expiratory flow limitation. Now, if we have some amount of positive pressure from above, which sort of stents this airway open, then, which is the peep, which is the peep, then this can, to some extent, help to overcome the amount of negative pressure which the patient has to generate before any other flow is given. So we set the PEEP at 80 to 90% of the intrinsic PEEP just to overcome this amount of effort which is required. And this reduces the work of breathing. This phenomenon will especially come into phase, especially when we are weaning the patient of COPD from a ventilation. Right? Because that's where this phenomenon becomes very, very important. It does not occur during the phase when they are being ventilated. There we can give the PEEP at some level 4 or 5, a minimum amount of PEEP. In asthmatics, we don't even give that. But when it comes to spontaneously triggering their breath during the weaning phase, that's when we have to look specifically for the amount of auto PEEP and set the PEEP in the ventilator PEEP at around 80% of the auto PEEP. And that will obviously reduce the trigger work of breathing which the patient has. Now coming to what's called double triggering. Now double triggering, you can see on the waveform here, normal breath, suddenly 2 breaths together. Again, normal flow, normal flow, normal flow. Same on the pressure waveform. This is a pressure scaler of a volume mode, and you can suddenly see 2 stacked together. Now, this is a rather common phenomenon. The problem, obviously, is it's pretty obvious what's happening here. We are giving double breaths. So double breaths will obviously lead to breath stacking. It leads to inappropriately large tidal volumes being delivered. It leads to excessive minute ventilation, right? And that can be deleterious, especially when we are looking for a lung protective kind of ventilation. The most common cause for double triggering are a mismatch of the mechanical breath, especially when the mechanical breath I time is too short as compared to the neural I time. My requirement is much more, the machine is giving much lesser. So I will double trigger. This also occurs because of another reason. When there is insufficient level of pressure support in a patient with extremely high respiratory drives. For example, patients who are with acute lung injury, where their lungs are inflamed. I'm repeatedly mentioning the word acute lung injury, although it's no longer a term which is used, but you should understand what I mean is a patient with inflamed lungs, where the drive becomes much more, the lungs are grossly involved, and the drive is very high. Here, if you have insufficient level of pressure support, and given the high drive, there can be a large amount of double triggering. Now, double triggering on pressure support ventilation especially occurs when obviously your pressure support levels are too low. Here, the ventilator has not met the demand for tidal volume. And this specifically occurs patients of ARDS, where the lung compliance is very low. So the expiratory flow trigger is reached very soon. So, you know, there is called an expiratory flow trigger, which is at default 25%, right? So when you see that, when we have a flow waveform, a pressure support, cycling occurs, it's flow cycle, right? So the flow cycling occurs when the flow is 25% of the peak flow. Now the lung compliance is so low that the peak flow is also too low, and the 25% comes very fast. So rapidly, the flow occurs, the cycling occurs from inspiration to expiration, right? And the inspiratory time becomes shortened. Just because the inspiratory time becomes shortened and the patient's requirement was too high, obviously there is a mismatch. And since there's a mismatch, it leads to double triggering, and that leads to this breath stacking. So this is the basic phenomena behind why this is occurring. So this double triggering on pressure support ventilation especially occurs as a reflection of the poor compliance of the patient's lungs, and that the pressure support is too low to allow for that much volume to be delivered with that pressure setting. So either we change to a lower trigger, right, which allows the prolonged insufflation time. That means we reduce the expiratory flow trigger to around, say, 10%. So the flow has to fall to up to 10% of the peak flow before the cycling occurs, right? We change the expiratory flow trigger to reduce it to around 10%. Or we increase the pressure support to increase the tidal volume. So these are the two ways in which we can avoid and match the requirement of the patient and avoid this double triggering on pressure support ventilation. So here you can see that if you set it at a conventional 25%, the cycling will occur. If you reduce the same expiratory cycling to around say 10%, then you have a longer inspiratory time and you have a more chance that the patient will get that much volume as the patient requires. The inspiratory time is prolonged, so the patient's requirement for inspiration is there. Obviously, the volume which is delivered will depend upon the compliance of the system, right? If the compliance is very, very poor, you obviously may have to increase the pressure support as well. So a combination of increasing the support and reducing the expiratory flow cycle to around 10%. So that is what is going to lead you to give adequate ventilation and an adequate inspiratory time for these patients and satisfy the patient's demand for volumes. Right. So in a nutshell, double triggering is caused by high drives, low tidal volume, short inspiratory time. Solution, increase the inspiratory time. Okay. We can, when we talk about increasing the inspiratory time, we can shift from a volume control to a pressure control mode. Why? Because the pressure control is a decelerating flow pattern. Invariably, the inspiratory time for in a pressure control mode is slightly longer than that of a volume control. Right? We can theoretically increase the tidal volume, but obviously that will be the last step to do because we are deliberately keeping the tidal volume low for a specific reason, for being lung protective. We can change from a volume assist mode to a pressure control assist control or a pressure support mode. And obviously when it becomes too much and the double triggering is a constant phenomena, we can sedate and we may even resort to paralysis, but that will be the last step. Now coming to what's a relatively new one called reverse triggering. Now reverse triggering is a relatively new kind of asynchrony which has been, which is the exact origin of it is still not very clear. Now this is classically seen in patients who are deeply sedated, right? Here the inspiratory efforts are being triggered by the ventilator rather than by the patient. So as soon, and it is seen in this form, there is a ventilatory breath and followed by there's another breath which occurs. You can see here a ventilated breath followed by another breath. And mind you, this breath is not being triggered by the patient. Rather, it's being triggered by the ventilator itself. And this is also called respiratory entrainment. The thing is that this can occur at any stage or any phase of the respiratory cycle. It can occur during the inspiratory phase. It can occur much later during the inspiratory phase, during the expiratory phase, and it will appear differently when it depending on which phase it actually occurs. What it leads to, it causes breath stacking and hyperinflation and augmentation of tidal volume. And this is very, very, very well seen in a pressure mode as compared to a volume mode. I'll show you how it looks like. You can see in a pressure mode, it's a pressure mode because obviously the plateau pressures, you can see it's fixed. It's fixed. The pressure is fixed. So this is a pressure mode. You can see that there is a flow graph and there's another spike in the flow graph, as you can see right here. This says that something has led to a change in the flow pattern, a decelerating flow pattern, which normally should be just coming down gradually. Suddenly there's a spike in the same. So this says that there is some kind of a second breath which has come into the picture, and this second breath has not been triggered by the patient. It's been triggered purely by the ventilator. Right? So a flow scaler will show you the reverse triggering in a pressure control mode. When you come to volume control, it's a bit more difficult. In a volume control, if you have set an inspiratory pause, since a volume control mode, here the flow is fixed. It is not a decelerating flow, it's a fixed flow. So you will not see much in the flow scaler. Rather, in a pressure scaler, you can actually make out that if you have set an inspiratory pause, the plateau pressure waveform may not be very, very clear. It may become blurred. As you can see right here, this was a perfect normal pressure time waveform where you can see a peak pressure, you can see a plateau pressure. But here you can see the blurring occurring here. Suddenly the plateau waveform seems to have gone off, and rather there's a spike there. So this can give you an idea that there is some kind of second breath which has been triggered off during the same breath. In a volume control, you can see reverse triggering, especially if the reverse triggering occurs later in part of the respiratory cycle, more towards exhalation. When you see that, there you can see in the expiratory phase in a flow time scaler. Here you can see the normal flow should be like this, going down to a peak expiratory flow rate and slowly, gradually coming up. But if you see something like this, which looks, I'll come to the later slide, which looks like early cycling. You see a flow here, which is upwards. Upward flow on a flow time scaler means towards the patient, right? Why is there in a flow time scaler there's a flow upwards and a flow below? Upward means towards the patient, below is away from the patient. In the expiratory phase, if you see a spike towards the patient, in a totally paralyzed, deeply sedated patient, it says that another breath has been given during a later half of the cycle during the expiratory phase. So this is how we find out that in a volume control mode, there's reverse triggering. Either there will be loss of the plateau pressure curve, or if it is a later part of the cycle, the reverse triggering is occur, you can see something which occurs in the flow waveform, where you see something like early cycling in the flow waveform. I'll show you what early cycling is in the subsequent slides. So if you see a positive deflection in the flow waveform, it also suggests that there is reverse triggering. And if these two phenomena occur in a deeply sedated or a paralyzed patient, it is reverse triggering. Same thing here, pressure control. Since the pressure, the flow waveform is variable, it is best seen in the flow time scaler. You can see a spike in the flow time scaler. And if it occurs later in the cycle, you can see the same thing as you can see here, the same deflection in the expiratory phase here. What is the solution? Now, the cause of reverse triggering is obscure. There are purported to be multiple causes, not really clear why it occurs. So the solution, obviously, it's a part and parcel of the deep sedation and paralysis. So sedation is to reduce sedation and neuromuscular blocking agents in early severe ARDS. Reverse triggering may occur in patients with an inflamed lung and without inflamed lung also, and is directly thought to be because of the deeply sedated paralyzed state where the ventilator itself is trying to give an extra breath where it is not required. So we have to be wary. Just because we have sedated paralyzed doesn't mean another breath cannot be there, right? So that is what is the take-home message from the reverse triggering process, that there can be another breath even during a controlled mandatory ventilation. And one should be wary for that, and especially look out for it. And when you look out for it, you actually see it. And you can see that this can actually lead to disproportionately large tidal volumes being delivered, what's called breath entrainment. And that can lead to harmful ventilation for the patient. Now coming to the next trigger asynchrony called auto-triggering. Now, auto-triggering is one of the most commonest thing which we see quite often. Here, basically, the trigger which we have set is probably too low that any exogenous or extraneous impact leads to the ventilator presuming that the patient has triggered a breath and it gives an inspiratory efforts. Right? Although it is very commonly seen, it is quite difficult to recognize. It's very frequent in non-invasive ventilation because of expiratory leaks. And how do we recognize it? When there's an unexplained high respiratory rate, we have set a respiratory rate of 12, the patient is triggering at 40. There has to be some reason to it. Absence of airway pressure drop at the beginning of insufflation, the negative spike which comes before the pressure waveform starts, that is not there. So these are just rapid breaths without any negative deflection. So that can also give an idea. This is probably just an auto-triggered breath. There was no patient's effort being involved in the same. And in case it is occurring in pressure support, then the cycles will be very, very short, very, very rapid, very, very short breaths. So this is exactly how auto-triggering looks like. Multiple breaths, just one after another without any specific trigger being associated with it. This occurs when the trigger is too sensitive or non-respiratory factors have been triggering the ventilator. And what could be the non-respiratory factors? There's a lot of things. Cardiac oscillations, leaking from a chest drain, a bronchopleural fistula, which leads to a constant to-fro movement, which can confuse the ventilator. Water condensation, sloshing and bubbling in the circuit, the to and fro movement of the water can itself, the ventilator circuit feels that there is a negative effort because the water is moving to and fro, and that can trigger a breath. Large volume of respiratory secretions within the circuit. For example, patients of bronchiectasis where copious amount of secretions being produced. Swallowing efforts by the patient can be misinterpreted as a diaphragmatic contraction, or vomiting can be misinterpreted as a diaphragmatic contraction, and it gives a breath, a negative effort, and can be given a breath. Peristalsis in a massive hiatus hernia or intrathoracic bowel loops by itself can cause deflections, especially if your trigger is set at a very less level. Muscle contractions due to external pacing. Transmitted movement from patient transport or repositioning, or inappropriately, obviously, high sensitivity levels because you have set the sensitivity at, say, just 0.8 liter per minute flow sensitivity, or a trigger of -1, and it's too low, and every external force is actually triggering off the ventilation. So solution obviously is to adjust the trigger to a higher setting. Increase the flow trigger to, say, 2 liter a second, or you can reduce the pressure to -2, and see accordingly whether the number of auto triggering is reduced. In pressure support, as I said, this leads to rapid small breaths, right? Here again, we obviously have to optimize the sensitivity, correct the leak, remove the condensate, whichever is there, whichever is causing this auto triggering. In non-invasive, it is very, very common, as I said. Sorry, we'll go back to the previous one. In non-invasive, it is very common. Why? Because of the excessive amount of leak. The cycling will not occur at all, right? It will not reach the maximum support level in which the settings has been done. There's a constant leak. The maximum flow will not be achieved at all. And just because maximum flow is not achieved at all, it will automatically just continue to give breath after breath after breath after breath. So we have to correct the leak. And we have to optimize the settings in such a way that there is proper triggering. Now coming to the flow asynchronies. We finished the triggering asynchronies. We come to flow asynchronies. Flow asynchrony is inadequate flow or insufficient flow for what the patient requires. So the flow asynchronies is best seen on the pressure time scalerer, where you can see a scooping out of the pressure time scaler here. So when there is a negative, so what we say is that the flow rate is inadequate to meet the inspiratory demand. A negative pressure is generated because the patient is taking too much negative inspiratory effort. So what's happening is that instead of the pressure waveform, after the negative deflection, which is the trigger, you can actually see the waveform being deformed and become scooped out. So this is called scalloping. This word is called scalloping. And it just suggests that the flow rate is too low. And once we increase the flow rate, and how do we do that by increasing the flow rate? We increase the pressure support. So that leads to a more normal looking pressure time curve. So this is a deranged kind, and this is a relatively normal kind of pressure time curve. So increase the flow rate in a volume control, or convert to a pressure mode. Pressure mode has a decelerating flow waveform, so that adapts more better to rather than a fixed flow waveform. And it gives a maximal flow right at the beginning of the breath. So most of the demand which is there right at the beginning of the breath is matched. So whenever you see the scalloped flow waveform in a volume control kind of a setting, we can always change it into a pressure setting where you have a decelerating waveform, and probably helps. And third thing we can also do is increase the steepness of the ramp, thereby increasing the rate of flow right at the start. Right? So in certain ventilators, it gives the rise time or the ramp 1, 2, 3 or so. You can increase the steepness by reducing it to 1. So maximum flow right at the start, So this flow demand, which is there right at the start, is matched. So when you talk about ventilator related, it could be ventilator related or patient related. Ventilator related is in volume control ventilation, the flow is set too low. In pressure control and pressure support, the applied pressure is too low and the rise time is too long. So obviously the solution is increase the inspiratory flow, switch to a pressure mode and reduce the rise time. And the patient related factor is obviously an extremely high increased ventilatory demand or an increased neural drive. What could be the causes? It could be a high neural drive in the first place, or it could be agitation, fever, restlessness, metabolic acidosis, anxiety, pain, and all those factors which increase your ventilator requirement, ventilator demand. And that demand cannot be met by a fixed flow settings. So then this kind of a combination of factors occur, then you have inspiratory flow, insufficient inspiratory flow, and we see it by in the means of scalloping of the pressure waveform in the pressure time scaler. Both insufficient flow and excessive flow, both are equally harmful, right? So this is something which I also want to get into the perspective of people, that just by blindly increasing the pressure support doesn't really help most of the time, because what happens is very high level of pressure support leads first of all to over assistance, alkalosis, hypocapnia, and on top of that, if we sedate, there's a reduced respiratory drive. Excessive flattening of the diaphragm occurs. Excessive flattening leads to long-term diaphragmatic weakness and paralysis. It leads to an excessive amount of sedation will lead to myopathies, central apnea, decreased magnitude of effort, and ineffectively leads to ineffective triggering. A large level of PS will also lead to large tidal volume, a very long insufflation time, very small expiratory time, incomplete expiration, and patients with COPD lead to increased auto PEEP. And because of increased auto PEEP, we have discussed before that there could be trigger asynchrony, where the patient has to do more effort to overcome the auto PEEP to trigger the breath. So that leads to increased effort to trigger the breath. So both a very high level of PS and a very low level of PS are both dangerous. So one has to be in the exactly appropriate levels. So in most of the previous few slides, we discussed that increase the pressure. But mind you, increasing the pressure also has its own set of problems. So an appropriate increase in pressure should be targeted, and that appropriate increase should be determined based on, first of all, whether the patient is in the weaning phase. One. Second, what is the background pathology of the patient? If the patient has something like COPD, exacerbation, excessive high level of PS can lead to large volumes, increase in air trapping, and further worsening of condition. So one has to be very, very cautious regarding the same and constantly look at the waveform. Now coming to the cycling asynchronies. Now we're coming to the last part, there's a cycling asynchrony. So we talked about trigger, we talked about the flow asynchrony. We now talk about the cycling asynchrony. The cycling means basically transition from inspiratory to expiratory phase. And the asynchrony can occur because of two reasons: too long an inspiratory time or too short an inspiratory time, right? So when there is too long an inspiratory time, when there is too short an inspiratory time, let's talk about premature cycling. Premature cycling means too short an inspiratory time. The patient wanted more breath, but the ventilator decided that no, this is a time to cycle from inspiration to expiration. The inspiratory valve was closed, the expiratory valve opened, and all the air came out. But the patient continued to require breath. So how do we see that? This occurs because there is a mismatch between neural requirement, that's the neural inspiratory time, and the machine determined inspiratory time. When there's a mismatch and the neural inspiratory time was longer than the machine inspiratory time, then obviously there's premature cycling. A premature cycling is very well seen in a flow time scaler. I told you in the previous slides that the flow time scaler, the positive deflection means movement of air towards the patient. It is the inspiratory phase. Movement away from the patient is the expiratory phase. That's why it's below the baseline. if we see in the expiratory phase, a positive deflection, something which we even saw during reverse triggering, if you remember. So this is, why is this happening? Is because the patient is continuing to try to breathe inside. So the flow of air is towards the patient, even in the expiratory phase. So this leads to a positive deflection during the expiratory phase, where they should have been straight down and like this. Rather, there's a positive deflection expiratory phase, which shows continuation of patient effort. And this corresponds to premature cycling. Premature cycling. Here you can see in the esophageal waveform that there is a negative deflection associated with this. That means that the inspiratory phase was still going on. The negative deflection on the esophageal waveform means that the inspiratory effort is going on. So there is still going on of the negative deflection in the esophageal part. You can see this corresponds to this. You can see this happening right here. So this correlates with premature cycling. So effectively, the duration is shorter than the inspiratory effort of the patient. Sorry. How do we correct it? In assist control, there is inadequate setting of inspiratory time. So when it comes to volume control, we should prolong your inspiratory time by decreasing the inspiratory flow or increasing the tidal volume. So a slower gradual rise in the flow or an increase in volume should try to overcome this premature cycling problem. In pressure control, we increase the inspiratory time. In pressure support, it is very frequent in patients with restrictive mechanics. Restrictive mechanics means patients who are recovering from ARDS, poor compliance lung, high drive, short time constant, as you have seen previously also, that the time constant is too short. The transition from peak inspiratory flow to and the flow fall to 25% is actually very less. So here the cycling is occurring much faster. So we have to increase the inspiratory time. How do we increase the inspiratory time? Is by decreasing the cycling threshold to less than 25%, so say 10% or 15%. So we have effectively increased the time which is there for inspiration. Now, it is sometimes very obvious because you can see in the expiratory phase that dip. But sometimes it's actually difficult to recognize if you don't have a diaphragmatic signal, that is, you have NAVA probe, esophageal probe inside, which shows the EADI signal, or without an esophageal manometer in place. So sometimes it's difficult to recognize as well. But if you see this classical spike in a spontaneously breathing patient, it says that your cycling is premature and you have to somehow increase the inspiratory phase. The exact opposite is delayed cycling. Delayed cycling means that the patient's neural effort decided that yes, the breath is over, but your ventilator settings is such that the ventilator hasn't decided the breath is over as yet. So too long an inspiration, right? A too long an inspiration disproportionate to what is required for the patient. This is, while that was seen in a flow time scaler, this is very classically seen in a pressure time scaler. In a pressure time scaler, if you see, this is the inspiratory phase, this is the exhalation phase, again inspiratory phase, exhalation phase. In a pressure time scaler, if you see a positive spike towards the end of the inspiratory phase, the positive spike is occurring because here the patient is trying to exhale while the inspiration is going on, right? So there is movement of air from both sides. Since there is movement from both the sides, so there is an increase or a spike in the pressure towards the end of the cycle. So that spike which you see is occurring because there is sudden rise in the pressure towards the end of inspiration. That's occurring because the patient is trying to blow out at the same time the ventilation is trying to give air inside. So that leads to the spike here, and that can be seen on a pressure time scaler, and that can tell you that there is delayed cycling. So how do we deal with it? In assist control, there is obviously inadequate setting of tidal inspiratory time. The inspiratory time is too long. So we can increase the flow in volume control ventilation. So rapidly increases the flow, the time, inspiratory time becomes short. In pressure control ventilation, it's a decelerating waveform. The inspiratory time is already long. So we can decrease the inspiratory time proportionately so that this phenomenon does not occur. In pressure support, the cycling threshold probably set too low. It is set at 10 or 15% rather than the baseline of 25%. It should rather be set much more higher. It should be set at around 30 or maybe 40%. So here, the cycling threshold needs to be increased. This is very common in patients with COPD. Why COPD? Because here the time constant of patients' alveolar units is very long, right? So a long time constant means that it is taking a very, very long time to exhale. So the inspiratory time needs to be short and the expiratory time needs to be long, obviously, right? So here, especially in patients with non-invasive ventilation, where there's a lot of leak, we can actually increase the expiratory flow threshold from 25% to say 40 or even 50%. Right? So we increase the cycling threshold or reduce the pressure support, because excessive pressure support in a patient with COPD will lead to excessive tidal volume. More the tidal volume, the more time it requires for the breath to come out also, because there is expiratory flow limitation. So avoid giving too high pressure support, increase the cycling threshold or decrease the rise time so that at least the expiratory time is given adequate. This is also sometimes difficult to recognize without esophageal or a NAVA catheter in place. So effectively, the conclusion is that these asynchronies are frequent and they are associated with poor outcome. There is a cause and effect relationship also. They can be sometimes easily identified: wasted efforts, double triggering, reverse triggering, premature or delayed cycling. These are more difficult to recognize, but one needs to be aware that auto triggering, reverse triggering, premature and delayed cycling exist, and we actively look for it. In difficult cases, esophageal pressure or EADI, or that is a NAVA catheter, can be used. And then once we know what is the basic problem, we can always try to manipulate this entire problem by changing the ventilatory settings. So we have to observe the patient, spend more time on the bedside. And even now, if most of us go back and look at most of our patients' ventilator screen scalars, you can actually recognize one or two asynchronies easily, and sometimes much more than that. So, as I told you again, friends, that it depends whether we need to deal with it or not. Asynchrony is bad. Sometimes it's unavoidable. But one has to take steps to overcome this asynchrony based on what is the condition of the patient, at what stage of the ventilatory cycle the patient is in. Is it in this initiation phase, maintenance phase of the ventilation, or during a weaning phase? And the steps have to be directed accordingly. The bottom line should always be to make sure harm is not caused to the patient. Even if you have to sedate, you sedate, but sedation should be the last step. Sedation will not be the first step. First step will be to identify and to fine-tune your ventilatory strategy so that the asynchrony or the demand problem between the patient and the ventilator is matched as best as possible. Thank you, and I'll be happy to take any questions that may be there.
So thanks, Dr. Srikanth sir. Kindly stop the share screen. And
Stopped it.
Dr. Ranjit sir, there are no questions so far. Any comments from your side, sir?
Well, I think good evening, everyone. And Dr. Srikanth, as usual, has made the topic very easy. It is not so easy as I can tell you. And the way he has spoken, as if it was, we were thinking that it's just a cup of tea, because it's a cup of tea to, it's such a very well, I don't have words to tell that how easily he has told such a difficult topic. And we intensivists, we know that what we deal with day to day with our patients, when the patients are on ventilator, because you are interacting with such a machine which is very fast, but very stupid, and you are slow, floppy, but you are a brilliant thinker. And this interaction is definitely going to create some amount of asynchrony. And if the asynchrony index is going more than 10%, as Srikanth has rightly said it, the mortality also increases. So in those ICUs where you find that most of your patients are constantly sedated and the paralyzed, you surely know that you don't have a Dr. Srikanth there. So it takes time. It takes time. You have to stand by the side of the patient, see the reaction of the patients. For example, this reverse triggering, very interesting one. It's basically the paper came out in Chest 2013 by Acumenki, if I'm not wrong. And he came out with this paper and he formulated that basically might be the stress receptors and the vagal C fibers. They are basically stimulating the Herring-Burger reflex. And that causes the diaphragm to trigger the ventilator. That what is known as reverse triggering. And basically, you can find this thing when you stand by the side of the patient in the night, when the patient most of the times are either sedated or sometimes paralyzed by a very smart senior resident. And if you reach there in the night, you can find a reverse triggering. It's not so easy to find in all the patients. It increases the tidal volume. There may be chances of volume trauma, but we have very insufficient evidence now. But it's really of very good, in fact, theoretical as well as a practical interest by which generated. Especially about pressure support. Most of the patients that fail to get weaned due to this inadequate cycling of pressure support. And you have to know about the ventilator, you know. One ventilator will say inspiratory termination. Another ventilator will say expiratory sensitivity. Another ventilator will say flow cycle. So if you don't know your ventilator well, especially the residents, the terminologies of the ventilator, you'll just get baffled. So the expiratory sensitivity or the inspiratory termination in COPD patients, as Srikanth is telling, it has to be kept a bit higher, that is around 40 to 50%, because the inspiratory time has to be short and the expiratory time has to increase. So, or you can increase the flow. If the flow is increased from, suppose, I have seen many, because nowadays during the COVID, everybody is becoming a specialist in BiPAP and ventilator. All the medicine specialists also have never used these machines. They are coming and think, oh, we have to give a support of 6 and 12. So that is not the case. One of the most difficult one of operating a NIV, the main reason of failure is this leak and this auto triggering and one of these asynchronies. And if I don't know how to set the rise time, how to set the ramp, and how to set this flow trigger, definitely I'm going to lose my patients. And we are thinking, oh, we are doing everything right. I don't know what is happening. So you don't stand by the side of the patient. See the sternocleidomastoids are walking very high. The patient is basically fighting with the ventilator. You don't have any clue. You just go on giving midazolam. So such an important topic, Dr. Srikanth has told in such a simple way. The flow, how the flow starvation should be seen, fantastic. But by seeing the initial phase of the pressure time graph. Beautiful way of Dr. Srikanth. I think I have very less words to congratulate you and really have given a very nice talk. And I just want to ask you that I have one question to Srikanth. That do you find your that is the amount of asynchrony that you find in your ICUs? Which one is the most common that you find?
See, the most common would be double triggering. Actually, if you ask me, double triggering and ineffective breaths, that will be the most common thing. But since we deal with a lot of, I would say, we are biased towards a more pressure mode, effectively, right? We have shifted mostly from volume to totally pressure-directed, pressure-driven modes, given the flow characteristics and all. So a lot of premature cycling, especially we see in patients of ARDS as well. On a very practical note, probably the most common one, which is probably the most commonly missed, is basically delayed cycling, which we do on NIV. So that is something which is probably the most common thing, because in NIV we are least bothered whether the patient is doing breathing, not breathing. We have said what is the expiratory flow trigger. We have said we are not really bothered. Nobody is actually looking at the machine, at the volumes which are being generated with every breath. So this is only possible when we have given non-invasive ventilation to patients with a ventilator, so that we can actually judge what volumes are being given, what is the flow characteristics of those volumes, whether there is premature, delayed cycling, and we see a lot of them, especially when we apply NIV. So NIV is something where you can, if you want to look for asynchronous, you'll get it. Definitely you'll get it. I mean, the rate is very, very high. Whether it is totally avoidable or not, that is a different question altogether. If you are able to basically provide what is required without too harmful ventilation, because the patients, ultimately NIV totally depends on the patient's own drive. Right, you really can't try to manipulate that too much, because here the patient has breathing in his own way, in his own pattern, in a lot of things. Certain patients you might have seen that you apply NIV and they just start breathing very, very fast. You remove it, they start breathing slowly. So this is how the body behaves to any kind of thing which is being applied onto them, and how we can fine tune them so that you can get them onto NIV at the same time, get the benefit and not cause harm. So that is where it comes into the picture. So effectively, ask me, for NIV, you will see a lot of asynchronous. On ventilation, we see a lot of ineffective breaths, one, and we see a lot of premature cyclings, another. Now, premature cycling, I have mentioned in my talk that it is actually difficult to find out. It's difficult to see. But if you put a patient of ARDS, especially who has had a very, very bad, especially we had this 2 years of COVID and all that stuff, if you put those patients on a pressure support as you're weaning them, you can see a lot of premature cycling quite often than not. So that's when you have to fine tune. You reduce the expiratory flow sensitivity to say around 10%. You increase the pressure support to some extent sparingly so that your tidal volumes are matched. So that's where it comes into the picture. You have to spend time on the bedside. I mean, if you don't spend time on the bedside, you really, really, really won't get to know any of them. Now, I think that's what we see in our practice, day-to-day practice. It's not possible to stand there forever, but yes, mostly that's what you see.
Yeah. So I think question has come up, Dr. Srikanth, how to measure the asynchrony index practically?
See, asynchrony index being measured is more for study purposes, if you ask me. Nobody sits on the bedside and starts measuring asynchrony index. The thing is, most of the studies have taken different time frames, say 15 minutes, 20 minutes. They have observed, they have seen the number of asynchronous breaths and total breaths, normal plus asynchronous multiplied by 100. And it's after all a ratio. The time frame really should be enough so that you don't miss out on major asynchronous. It should not be too long that you are just standing on the bedside or not standing on the bedside. Most of the studies have 10 to 15 minutes, and they have taken multiple observations, 6 to 7 observations on the same patients or different time frames, so that they can catch asynchronies as it occurs. Sometimes asynchronies are more common in the night as compared to the day, when it's being monitored, not being monitored, when you're actively doing something with the patient, not doing. So all those things are there. So it has to be, different time frames have to be taken. It has to be an average of all of them, not just in separation.
Yeah. So exactly, Dr. Atul, so it is more of a research tool, asynchrony index. The idea is you should be able to pick up whether there is asynchrony occurring or not, and that you get by looking at it frequently. You know that there is asynchrony going on, whether it's infrequent or frequent. Otherwise, it's more of a research tool, asynchrony index, like Sir has said. So I think we'll move on to the second part. I'll just share my screen.
There is one more question, how to differentiate between premature and delayed cycling. See, they are totally opposite end of the spectrum, right? As I said, premature cycling, your inspiratory time is too short, right? And it has cycled to expiration. So what are you going to see? You're going to see changes during the expiratory phase, right? So where do we see changes in the expiratory phase? In a flow time scaler, because there is a positive deflection and a negative deflection. In the negative deflection, if you see a positive upward spike, it means the patient was still trying to take breath. The upward spike is occurring because the air is moving towards the patient. So that is premature cycling. Delayed cycling, means that the inspiratory time was too long. The patient wanted to exhale when the inspiration is still going on. So which phase of the cycle you will see? You will see during the inspiratory phase. In the inspiratory phase, you see in a pressure time scaler, where you see that towards the end of the inspiration, in a pressure time scaler, there is a sudden surge in the pressure. That's occurring because, as I said, the patient is trying to blow out when the air is trying to get in. So obviously, the combination of two will lead to a spike, effectively in a very rough kind of a way. So that leads to a spike in the pressure time scale towards the end of inspiration. So that is delayed cycling. Whether an EDI catheter is required or not, because the spike may be too small and the positive deflection may be too small in the expiratory phase, that is why the EDI catheter is required. If you can see it, obviously, then it is there.
Yeah, she is understood, sir. Thank you.
Okay.
I share my screen. Just to reiterate a few points from here. First of all, in auto trigger, you will not actually see any triggering going on. Very rarely you may see triggering. Okay, but point number one. Point number two, what is breath stacking? It includes both double triggering as well as reverse triggering. So breath stacking includes both. Now, reverse triggering, like sir has said, mechanism is not well defined. But what is postulated is that when the patient is deeply sedated, the ventilator delivers breath, and during this process, when the diaphragm moves, it triggers an active contraction of the diaphragm. That is whatever is thought right now. That is the current opinion. And how you counter it? Either you decrease the sedation or you paralyze the patient totally. So that is about reversing. Then in NIV, leaks are very frequent, right? Like Sharad said, it's a very high frequency of leaks. So please set the all the parameters properly to get the appropriate ventilation on NIV. And there is an option of leak compensation also, automatic leak compensation that should be put on NIV patients. That helps. And another thing is, when you are trying to measure auto peak, you need an expiratory hold. That is possible only if the patient is paralyzed or deeply sedated and not breathing actively. So what is to be done if the patient is not, deeply sedated or paralyzed, that is breathing spontaneously? So you look at the sternocleidomastoid activity, right? The sternocleidomastoid activity reflects the effort that the patient is taking, and that reflects upon the breaths, ineffective as well as effective. So you start in your external PEEP and look at the activity of the sternocleidomastoid and see whether it's decreasing and whether your efforts are coming, the volume that you are generating is coming in sync with your sternocleidomastoid activity. That is another way of, trying to optimize external PEEP to counter auto PEEP in COPD patients. So just a few points I wanted to reiterate from the entire beautiful session that sir had taken. And we thank him actually. He's suffering from COVID. As you can make out, he was coughing and looking a little parexic. Thank you, sir. And I'll just share the screen and run you through some abnormal waveforms which would be helpful to you. Is my screen visible?
Yes.
Just 1 minute. It's not going full screen. Okay, so just run you through some abnormal waveforms. And please be aware of one thing, that different ventilators have different softwares, and the kind of numbers and settings may vary a little from one ventilator to another ventilator, right? So you are working in an ICU for 5 years with a particular ventilator, and somebody else starts talking about ventilation and he's using another ventilator. There might be a slight mismatch in the type of numbers and settings that the other person is talking about, and you should be aware there is a difference in the software of each ventilator type. Now, the first thing I want to talk about is the use of FE loop to diagnose COPD or airway obstruction. Something I think is very useful, but is not really prevalent. The people are not knowing about this, especially our younger lot. So just show you this. I think you will find it very useful in your practice. So this is a normal flow volume loop, and you can see here, this is inspiration and this is classic expiration. Now the point here is, this is a straight line. This is the expiration here occurring, and airway obstruction and COPD is characterized classically during expiration. There is limitation in inspiration also, but the major resistance factor comes into play in expiration, because normally expiration has greater resistance than inspiration because the lungs collapse during expiration. So this is the same loop now with increased resistance. So as shown here in red, you see there is scooping here. There is an inward scooping. That is an indicator of obstruction taking place. Now, when you put the patient on the ventilator, there is an increased resistance inherent to the fact that the patient is on the ventilator. So generally, there will be a slight scooping in almost all the patients. Now, the causes of pathological scooping are COPD, status asthmaticus, or if you have put a narrow tube, a tube which is too small for the patient, or if the tube has been there for too long and has got encrusted with secretions, or if there are a lot of secretions, or if there is bronchospasm. So these are the conditions which we deal with. And of course, there are pulmonary conditions which can have increased airway resistance. Even ARDS, though a parenchymal process, has an increased airway resistance, because there can be, and there is generally, some degree of bronchiolar and bronchitis in these patients. Now, this is a classic example of COPD, flow volume loop. This is flow volume loop, and this is known as scooping in COPD. As you can see here, the peak expiratory flow rate is decreased and is slanting slowly and is scooping. It is not straight like this. Right? And here what you see in the circle is the volume of air which was trapped in the upper airways. So the moment the patient starts expiring, this does not meet any resistance. The resistance is in the lungs and in the smaller airways. And the air which was trapped or which was held in the upper airways and the tubing is expelled immediately. That is why you get this spike and then you get this scooping. So if you get this pattern, that is highly suggestive of COPD. And this is important because all patients do not give a history of COPD. Sometimes you may be having weaning failure because the patient is having increased airway resistance. These elderly ladies often have COPD and you do not get the history. They will start getting dyspnea, but they will limit their activity, so they will not report dyspnea. Little bit of cough they will get used to. And I've seen this frequently. This is not infrequent. And undiagnosed COPD and patient is not getting weaned off, and then you look at the flow volume loop, you can pick this up. And sometimes patient present with respiratory failure of undetermined etiology, and by just looking at the flow volume loop, you can diagnose COPD. And of course, if there is auto peep going on, you will pick it up, right? It is easy. You all know auto peep. In the flow scaler, it will not come down to baseline. And here also you can see there is auto peep going on here. Okay. But the thing is to pick up COPD from the flow volume loop, and this is called scooping in COPD. And of course, the other factors which can increase airway resistance should be borne in mind. Now, this is another classic picture of dynamic hyperinflation, which occurs in COPD or in status asthmaticus. Here you have your normal volume. This is the tidal volume, and this is your FRC. FRC is the amount of volume in the lungs during tidal breathing, which is present after you have exhaled, and this is around 2 liters. So if there is dynamic hyperinflation, that is, the patient is not able to breathe out completely and exhalation is incomplete, you will have volume trapped at the end of expiration, which will lead to increase in pressure at the end of expiration, which is called auto peep, and which each progressive breath you will have, and this green is increasing volume which is being trapped in the lungs. And this is the kind of picture you will get, and this is in a patient who is sedated and who is being delivered the volume, but ultimately the patient will not be able to generate a volume because the work of breathing is being increased if the patient is breathing spontaneously. So this is a characteristic picture of a patient of COPD going into dynamic hyperinflation or what is called auto peep on controlled ventilation. Now this is to show you another flow volume loop, and this is main stem bronchial obstruction. And this is here what I showed you. This is an expiratory scooping, which I talked about earlier. Now here the point is there is scooping in the inspiratory flow also. Normally in airway resistance increase, you do not get an abnormal pattern in inspiration, because in the process of breathing, increased resistance in the diseases is mainly manifested in expiration, because resistance is mainly increased in expiration. Because in inspiration, everything is dilating, right? The airways are dilating, the lungs are dilating, while in expiration, the lung is collapsing, the airways are collapsing, and in COPD, there is marked spasm also. So in cases of bronchial obstruction in the mainstem, as which may occur due to a tumor, due to a mucus plug, or various pathologies depending on the situation, you will get an inspiratory scooping also here. It will slow down flow. This is because it is a fixed obstruction, right? So this is another thing you can pick up from a flow volume loop. This is very easily recognizable. You all know this. This is a pressure volume loop. But what is important to realize is this. This is the inspiratory loop and this is the expiratory loop here. This is a process called hysteresis. Hysteresis is the difference here between inspiration and expiration. And inspiration and expiration are similar processes. Air is going inwards and then it is moving backwards. The process is supposed to be similar. But because of the changed compliance and the changed resistance during exhalation, it follows a different pathway. And this is called hysteresis. And this becomes important because in COPD patients, in increased airway resistance patients, there is a widening of this. The hysteresis widens as shown here. So this is another thing you can pick up. There is increased airway resistance. This is a pressure volume loop. Now this is a patient of ARDS. So can you tell me what this phenomena is called, which is circled? So this is called beaking. This is known as beaking. And if you are getting this, that means the pressures are high in your patient, right? So what is happening, as you can see, that with minimal increase in volume, you are getting a great increase in pressure. So this is a patient who should be not getting any more volume, and you have to decrease the volume actually, or decrease the pressure with whatever means you have. So this is known as beaking, and it signifies in an ARDS patient that he is being overstretched, the lungs are being overstretched. Now we come to the concept of plateau pressure. So plateau pressure is known to all of you. I just want to highlight that there are two components to plateau pressure. Now the first is called P1. This here is P1 and this here is P2. So plateau pressure has two components, P1 and P2. And you know, when there is tidal volume being delivered, a pressure being delivered, you have a peak pressure. And the plateau pressure you get only after you give an inspiratory hold or a pause. And then you get a P1, and a little while after that you get a P2. If you do not get a hold, a pause, you will not be able to get a plateau pressure. So why do you get the plateau pressure and why do you need the inspiratory hold? So that is because by giving the hold, there is something known as a stress relaxation factor which gives you the plateau pressure. It is able to tease out the difference. Okay, you have to give a pause to get the system in equilibrium, which is known as the stress relaxation factor, which is the P1. And then there is a pendular effect, which is P2. Normally, P1 is very close to P2. It is a concept, right? And the ventilator gives you a mean of this P1 and P2, which is your plateau pressure. However, in states of excessive flow, this is flow here, and you can see the flow is much more here. The difference between P1 and P2 can widen. The difference between P1 and P2 can widen to some extent. So this is just to show you the concept of plateau pressure and P1 and P2 in plateau pressure. So this is another question for you here. What is happening here? In the red arrows, what is being shown? Absolutely. So this is volume leak. As you can see here, volume is not returning to baseline. Correct. So this is another example. So what is happening here? Again, there is volume leak. Volume is not returning to baseline. So there is volume leak. Important to know that this is flow. Flow will return to baseline. All right. Flow will return to baseline, but the volume does not return to baseline. What is this? Anybody? This is a volume scalar. That much I'll tell you. This is a volume scalar. So this is actually expiratory valve malfunction. Sometimes these things also happen, and this is actually expiratory Just 1 second, is not more. This is expiratory valve malfunction. This is a problem with the software. So sometimes these things also happen because you see volume is turning to baseline. So there is no leak here. And then this is the second volume being generated, and this is expiratory malfunction. Now coming here, what is happening here? So this is volume, this is pressure, and here this is a PV loop. This is what it looks like in volume leak. The volume is not returning to baseline. And here you see this is the amount of volume leak. Again, this is flow volume. So this is how it looks on PV loop and flow volume loop. Now, what is happening here? Anybody? So this is auto PV. You can see this is flow, and the flow is not returning to baseline. This is on flow volume scalar waveform. So this is, you are very good at picking up on the flow scalar where it does not touch baseline, but this is how it looks in the flow volume loop, auto PV. Now, what is this? This is excessive volume being expired. Here, whatever volume was retained. So this is excessive expiratory tidal volume occurring here. Now just going to the last couple of slides, this is a concept called pressure time product. Okay, as you can see, there are two waveforms. This is esophageal pressure, which reflects the pleural pressure, and this here is the gastric pressure. Okay, you put in two catheters and measure the gastric pressure, and this is the esophageal pressure, which reflects the pleural pressure. And here, this is inspiration and this is expiration. So the patient starts taking a deep breath, negative breath, and you get a negative pressure. At the same time, the diaphragm goes down. So your gastric pressure rises. And the difference between the two is an estimate of the transdiaphragmatic pressure, which translates into the work done by the diaphragm. How effective is the diaphragm contractility? And that is important because 75% of the work is done by the diaphragm, and also diaphragm is a very important muscle contributing to 75% of the inspiration. Thereby, you can estimate the contractility of the diaphragm. Then this here denotes secretions. If you get something like this, it generally means that there are secretions present in your circuit, and this was first described by none other than Tobin et al. Tobin and Jobran around 20 years back have described this, and Tobin, is the author of our great book, Tobin's Mechanical Ventilation, and this can also reflect water in the tubings, or can reflect some degree of kinking. But if you are getting this, it generally means there are secretions. And this is the expiratory flow. And because the airways are narrow during expiration, they are more prominent during expiration than inspiration here. So this is something which can be used to pick up excessive secretions. Now finally, this here is to show you gross asynchrony. As you can see, this is gross asynchrony, and this is the esophageal trace, which reflects the pleural pressure, which reflects the efforts made by the patient. And because the efforts are totally erratic, you're getting erratic scalars in your flow and your pressure and your volume. It is all haywire. So this is gross asynchrony because of very irregular breathing efforts by the patient out of sync with the ventilator. Now, last slide. This is what? This is called ringing artifact due to fast rise time. So this is here, you can see, this is the rise time, okay? This is the rise time and this here is the flow scalar and you increase the rise time here, okay? This is a shorter rise time, this is a faster rise time and this is even faster. So if the rise time is inappropriately fast for the ventilator, you get this called the ringing artifact, right? There's an overshoot of this rise time which cannot be handled by the circuit and you get this waveform which is called the ringing artifact. Now, finally, the question of P-flat in PCV. So is there any relevance of measuring plateau pressure in PCV? Now, there is a relevance to measuring P-flat in PCV. The P-flat is not the same as your pressure control in P-flat all the time. In this situation, which is the situation where the flow is coming to zero before expiration starts, yes, your PCV, your pressure control will be the same as your P-flat. But in situations where the flow, inspiratory flow, does not touch baseline and expiration starts before that, your P-flat will be different from pressure control in PCV mode. So in these situations, you will get a different P-flat from your pressure control, and this can happen because of various reasons. Either your TI is short or some other reason, whatever your setting is at that time. So that, I think, was the waveforms I wanted to show you, just a bird's eye view, and hopefully you would have found them useful. But please remember that you have to integrate everything. You have to read, you have to see the waveforms at the bedside, and you have to ask your seniors. And there is no better teacher than the patient and the ventilator at the bedside in the ICU. And then you have to supplement it with the reading. In isolation reading and in isolation just picking it up at the bedside does not really culminate in the ideal way of learning. You have to accumulate slowly and steadily from your books and from bedside teaching and take the help of your seniors. And the books I would recommend for beginners is, I think, Pilgrims is a good book to start with. And you then finally crystallize it with Tobin's Mechanical Ventilation. Kindly, for beginners, do not read Tobin in the beginning. It is a heavy book and it is not understandable in the beginning. First, you should read a book which is basic like Pilgrims or whatever book you want to read. So I think that is all I have to say. And with that, I will stop the share. And if there are any questions, and if Dr. Chatterjee or Dr. Srikanth sir want to say anything, they are most welcome.
Well, thank you, Tapesh, Dr. Tapesh, for nice presentation. And I think it will be students as well also for us, because we are also constantly learning. Every day we learn. And again, I'll say it is a complex interaction between man and machine. Man is a brilliant thinker, but very slow. The machine is fast, but it is stupid. It is how the person who is running the machine that is very important, how you deal with it. You have said a very important point to see the stardicluidomaster that I was also telling. Just by the side of the patient, you can understand whether the asynchronies are going or not. And yes, start with a simple book and then go to a difficult one. And the best book is to stand by the side of the patient. Thank you so much.
Thank you, Dr. Ranjit sir. Srikanth sir, any comments, sir?
No, I think most of the things are more or less completed. I don't think there are any questions also. Although there was some question regarding leak and excessive demand of the patient, and I think you already covered those parts.
Yes, I think that is was one of the queries I put. So that was showed expletive malfunction.
Intentional leak versus unintentional leak. No, I don't really know what is intentional leak.
So,
What is intentional leak? I don't quite get that. There's no intentional leak in case of
intentional leak, I think you are referring to those patients who have, COPD and there's carbon dioxide retention. You want to open up one of the valves on the mask and let the carbon dioxide blow out. That is probably what he means by intentional leak. You have that mask and you open one of the pores and let the air leak out.
Sometimes in non-invasive ventilation, sometimes in non-invasive ventilation, we, especially with the helmet as an interface, sometimes when there is excessive pressure, we can just open a small port and cause some amount of intentional leak. I think Atul is mentioning that only. During NIV, there is sometimes we use intentional leaks.
Yes, that is the carbon dioxide if it's accumulated. So that's about it. Any other questions, sir? Any audience? So I think that's about it. So, Dr. Srikanth, sir, wish you speedy recovery. Thank you for spending time with your COVID pyrexia and cough. That was very nice of you and very supportive. Thank you very much. And Ranjit, sir, thank you very much. So, Ranjit, sir, should we have your helmet lecture next week?
Yes.
Okay.
You keep it now. I don't have any problem.
So next week is helmet lecture by Dr. Ranjit, sir.
Just wait. Just in the next week is 30th.
Yes.
So can you keep it around 7? Because
sir, I will talk to you. I will just get back to you offline. Okay. We'll just
thank you so much.
So thank you once again. Thank the audience for their patient hearing, and thank Cipla for providing the digital platform. Thank you.
Thank you.